Hello, everyone. Today, we're going to discuss about this wonderful review paper that came out just recently. Um, was received on November 29th and accepted on January 9th, and that by the first author was Patrick Wazorski from Mayo Clinic, Jamel Ortoleva. He is from Tufts in Boston. And Daniel Cormican. Daniel is in Pittsburgh, in Allegheny Hospital, and Troy Silhammer. And Troy is, I don't see any affiliation for Troy. This is a free paper that was provided in Twitter under ELSO. It was retweeted by ELSO. So essentially, this paper, what is a nice review paper, goes over about the overview of VV-ECMO, and essentially shows the indications of VV-ECMO is used for patients with severe acute respiratory failure. It goes through recent trials and evidence. And goes also some the cannulation techniques, patient selection techniques, has some wonderful graphics, a review of the cannulas. It has some winning strategies, the cannulation techniques, and the future outlooks of ECMO, which is a pretty wonderful review. So let's go, let's get started. So it shows that the article says, in this review, we examine the considerations for candidate selection for VV-ECMO, the evidence of utilizing VV-ECMO in respiratory failure, complications, and management of those, which is wonderful. And again, when we say VV-ECMO, we mean it's Venovenous. Essentially, we're talking that we have the drainage cannula. It's where we're pulling the blood from, which is drainage. And the second letter, it is the return cannula, when the oxygenator blood returns, return cannula. And then if there is an additional configuration, so let's say if you decide that the patient has cardiogenic shock, and you decided to add additional configurations to your circuit, and let's say you connect the circuit and you put an arterial return cannula, and then becomes a VV-A ECMO. So essentially, and this goes by the chronological sequence of changes to the circuit. So for example, you say if you have VV-ECMO here, it means that you have taking blood from the venous system and returning it to the arterial system. But this is not what this article is about. The article is about only for VV-ECMO. Okay, so essentially, I'm going to go through the introduction. All right. All right, let's jump to the introduction. So, ECMO, um, let's go through the summary points. So, essentially, the use of ECMO has exploded over the recent years. It provides both respiratory support in a situation that you have acute severe respiratory failure, both hypercarpic or hypoxic, or the combination of two. And remember, they used to tell them to have the old definitions like a type 1 or type 2 respiratory failures. So also in the key summary point says that the ECMO is an artificial mechanism of gas exchange that always aims to support while the underlying pathology is being treated. And that's a very important point. You want to have to apply the ECMO in a situation when you have a reversible condition, or you have a plan. You're doing a bridge to somewhere. You're doing a bridge to lung transplantation, or you, for example, if you have somebody with severe ARDS that you expect to recover and they need a little bit more time, and you're not able to manage the mechanical ventilation. You have very high plateau pressures, very high driving pressures, or refractory hypoxemia, then you apply the ECMO. So the introduction essentially goes, and this describes that ECMO is a means of oxygenation and decarboxylation, essentially treating the hypoxemic and the hypercarpic respiratory failure by both providing oxygen through the blender and the membrane, and also removing CO2 with a fresh gas sweep. Interestingly, also the ECMO provides some additional support in addition to the mechanical ventilation to help, especially in ARDS, to minimize the ventilator-induced lung injury, as you can see here. They describe. And this is essentially the EOLIA study that we're going to discuss in a little bit later. The authors go ahead in the introduction and mention that there is an explosion of ECMO use. It increased tenfold over the last 10 years. And we had like 10,000 runs in 2021. So it's a mnemonic. The last 10 years, ECMO increase 10 times and reaching 231 to 1, which is 10,000 VV-ECMO runs. And going through the use of ECMO, if you remember, it's the CESAR study was the first influential study that established VV-ECMO in 2009 during the H1N1 epidemic. Then we have the MERS, the Middle East Respiratory Syndrome, in 12 to 15. And more recently, we have the COVID, the SARS coronavirus 2 in 2020 up to currently. So then the article jumps into evidence. Okay, let's jump into the first, say, most popular trial. It's the CISO trial 2009. It's conducted in the United Kingdom during the H1N1 pandemic, essentially. So adults with ARDS, severe respiratory failure, and essentially in the Murray score of greater than 3, and or uncompensated hypercapnia were eligible for this trial. So again, what is the Murray score? It was developed by John Murray. John Murray, he was a professor at San Francisco, University of UCSF, I believe, and he initially described this definition back in the American in 1988, if I remember correctly, and essentially the score is has a so the Murray score can be from 0 to 4. It has two things. It has essentially several aspects. First, you have to have an X-ray. X-ray, and they're asking how many quadrants you have infiltrates. So if it's one quadrant, like you have your lens here, if it's only one quadrant, the score is 1. If it's 2 here and here, or here and here, it's 2, 3, and 4. So the maximum can be 4. Then goes ahead and asks, what's your PF ratio? So if your PF ratio is greater than 300, it's a 0. That's a 0 score. If you have a PF ratio of between 225 to 300, then it's gonna remove a little bit. But for example, if your PF ratio is less than 100, then your score remains 4. As the PF ratio goes, the score decreases in value. So essentially, let's say you have 4 quadrants infiltrate, so mild pulmonary edema, but your PF ratio is greater than 300, then your score is gonna be, it's gonna be actually 3. So again, for example, I'll give you an example. If somebody has infiltrated here, 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 and he has a PF ratio greater than 300, which is PO2 to FiO2 ratio, the higher it is, the better are your lungs, then your Murray score is 3. If your PF ratio less than 100, which is the worst, your PF ratio is 4. And there is calculator steps in between. The same with your PEEP. If you have this plus this on your ABG, and you are on a PEEP of greater than 15, you have a score of 4. If you're on just PEEP of 5, if you have a PEEP of 5, then you become 3. And so essentially, if you have and then I guess again goes for your lung compliance. If your lung compliance is, if you have all these things and your lung compliance is less than 20, essentially 19, you have 4. If your lung compliance is normal, having all these things, and your lung compliance is greater than 80, which is normal lung compliance, that means lung compliance is how many mLs your lung expands for each centimeter of water pressure. So it's 80 mLs per centimeter, and I believe this is a static compliance. And this essentially, it's your tidal volume divided by your driving pressure. So if it's for the static compliance, from the total pressure, I believe is the dynamic compliance. But 80, then if it's normal compliance, your score. If you have even all these things, then your score becomes low too. But if your compliance is extremely bad, if it's 19 or lower, then your score is 4. So essentially, the MERS score is a little bit of a, if you apply it correctly, not just by the chest X-ray, but if you use the blood gas criteria and the ventilator criteria, it's quite a nice score because it's foolproof. For example, one cannot somehow game or mislead the severity of respiratory failure, because you have to have a chest X-ray, you have to have a blood gas, you have to be on a high ventilator settings. And even if you try to get all these things right, and you have to measure the lung compliance. So if you put somebody, for example, with mild pulmonary edema, but has infiltration in all 4 quadrants, and somehow you mess your ABG and you get it, you think you get it on 100% FI2, but you got it on room air and miscalculated, and you put the patient on 15 OP erroneously, doesn't need it, then you calculate your lung compliance. Like lung compliance would not be horrible. It's going to be nearly normal. So you cannot really, if applied correctly, the MARI score would be a very nice score to use. So essentially they use the MARI score greater than 3. Remember, 4 is the maximum for or uncompensated hypercapnia. That means if you're on a lung protective ventilation settings, you allow permissive hypercapnia, and the worse your dead space is, the more extent is your ARDS and respiratory failure, the higher your CO2. So essentially, they got the pretty sick patients, and the PF ratio, as I mentioned, less than 75 with a mean MERI score of 3.4 at entry. They randomized the patients with this severe ARDS H1N1, and the one arm was transferred to a center, a specialty center that could provide ECMO, and the other, they did the usual conventional care that they were able to provide at that time. We know there was a notice that the ECMO arm also trying to have a little bit of less pressures and lower volume ventilations, and also got a little bit higher steroids, maybe reflecting the management in the specialty center that the patients were transferred. And maybe that was also the major criticism of this trial, that why did you transfer the patients? And you maybe what you're seeing is the effect of the center, not the effect of the actual ECMO. Regardless, there is a dramatic decrease in mortality in the ECMO arms, 37% versus 53% in the non-ECMO. And if you're taking your boards, it's something that can appear in any boards, medicine boards, surgery boards, critical care boards, anesthesia boards. So you have this difference in mortality. That means the absolute rate reduction is 16%. That is 53 minus 37, 16%. And they may ask you, what is your number needed to treat? So you have the 2 mortalities. You subtract the difference, you find 16%, and the number needed to treat is 1 divided by 16, which is 0.16, and you find that the number needed to treat is about 6 patients to save 1 life. You need 6 subjects to observe 1 change in the outcomes. In this case, was like 1 life saved. So essentially, the number needed to treat with this intervention is, for every 6 patients that were referred to the ECMO center, 1 have their life saved. which is pretty striking. And they go ahead and they calculate the risk ratio, the relative risk, sorry, which is 0.6, and the p-value is 0.03, which is significant. And again, here the authors interpret that due to the trial design, it was challenging to distinguish the true benefits of ECMO from the conventional management. And that was a major trial. So the Caesars published here, it didn't explode immediately. The use of it took a lot of convincing to go to the 10,000 cases in 2021, as we mentioned. And this is the graph of the growth of the ECMO centers and the ECMO runs. So you see that when I started my training around 2006, there are about nearly 200 ECMO centers, and they're doing about less than 2,500 cases a year. By the time I finished my fellowship in 2013, there are about almost 5,000 cases and about 300 centers, and then exploded steadily regardless of the pandemic, and reached to the 10,000 cases and almost nearly 700 centers in 2021. So it's if you want to predict the growth, it's gonna, one is not unreasonable to say that it's gonna keep growing in terms of forecasting. Next study that is summarized seems it's a Eolia study, a French trial conducted in 2018. It's very important to outline the selection criteria here. We have a PF ratio of less than 50 for 3 hours among patients with ARDS, a PF ratio less than 80 for 6 hours, or PCO2 greater than 60 with a pH of less than 7.25 for 6 hours. So essentially, they are people with severe ARDS, all of them, most likely, and with significant dead space or significant dead space ventilation. But imagine, in order to be in this situation here with a high CO2 and low pH, likely that means that your tidal volumes and minute ventilation is low because your lungs compliance is extremely bad. So they randomized them to either this or conventional management. All the patients are extremely sick. The PF ratio is about 73 on entry, and about half of the patients received pulmonary vasodilators. The duration from the intubation to randomization about 34 hours. So it's about, let's say, about 3 shifts, 3 12-hour shifts between intubation and so there's a little bit of delay there. What is interesting is that the trials terminated early for futility, but futility doesn't mean there is no difference, but the trial with the current power, the current numbers, the current power, was not able to reach the designated mortality assumption difference that was supposed to do. So essentially, what does it mean? That doesn't mean that it was futile in general, but the current design, if you kept going, would not have was not able to find the exact to reach the significance based on the assumed mortality difference when the trial was done. There was a lower mortality, but non-significant, on the ECMO, 36 versus 46%, about 10%. If I remember on top of my head, I think the expected difference is to find 20%, which is enormous. And the p-value is 0.09. That means about 9% chance that this was found due to a random variation. 35 patients crossed over to the ECMO, signifying the belief of the physicians that ECMO is necessary for those patients. And also is mentioning that these patients were sicker, and the ones who crossed over had higher mortality than the ones who did not cross over, but with an obvious selection bias. You don't cross over just randomly. You cross over because your clinician feels you're going to die. Certainly, if you don't cross over, about half of them died. There was another post-hoc analysis, a Bayesian post-hoc analysis that was done, which of course is not as strong as a primary a priori study. That they found that ECMO recipients, comparing to conventional management, had the lower mortality, and that was significant, like with a relative risk of 0.75 and a p-value of 0.03. Essentially, there was another meta-analysis of the Eolia and the Caesar trial that also showed some significant mortality difference, highlighted, but also with a grain of salt that this may incorporate the bias of the person who conducted the study at the priori. So essentially, the person who did those studies, they had an intention and bias towards proving that ECMO works. However, the direction and the magnitude of the mortality of those, especially the Eolia trial, cannot be ignored. Finally, there were some subsequent studies that were performed on Caesar study that showed that the intervention, the VV-ECMO application, was cost-effective, and the patients who were on ECMO had increased quality-adjusted life years. And that's important to mention because recently there is more and more evidence that patients who have lower oxygenation targets may not do as well as we expected before. So that'll be an interesting thing I'm looking to see for the upcoming years in the trials that will be upcoming years. And finally, going through the COVID-19 section, the authors here, they mentioned that there's no true randomized controlled trials in COVID. There were some emulated trials that showed encouraging results. There's some meta-analysis of observational studies looking at about 70,000 ECMO patients or more with COVID-19, and the factors with high certainty of evidence included older age and higher driving pressures that may benefit, and moderate certainly include males, chronic lung disease, longer symptom duration, mechanical ventilation, lower PF ratios, bacterial co-infections, and lower volume ECMO centers. And this concludes the first section of this wonderful review paper, and we are going to jump ahead about the patient selection, which is a very interesting topic. Great, let's jump to the patient selection. So the indications of ECMO, they're not written in stone. The most considerations are based on the two trials that we had prior, but the principle is, and highlighting here, is that ECMO is a temporary method of supports like mechanical ventilation, and should be used for patients who are on the pathway to recovery or transplant. So essentially, the patient has to have a reversible condition. For example, putting a patient with IPF and who's not a transplant candidate on ECMO is absolutely the wrong decision to do. It's an incorrect choice. Indications for VV-ECMO initiation include here the ARDS based on infectious or inflammatory causes. For example, it could be aspiration, could be chemical injury, could be any other inhalation injury from aspiration pneumonitis. We have the blunt chest injury, which is an important cause of reason to be on VV-ECMO. Refractory status asthmaticus, very important. We have placed several patients with excellent outcomes, and or a bridge to lung transplantation. So the common theme of all of this is a reversible condition in a patient who can be salvaged by buying some more time. Interestingly, going to the contraindications for ECMO. Again, here it highlights the recovery or transplantation, which is essentially recovery. But other contraindications could be include severe neurologic injury. And why is that? Because a lot of centers, when somebody goes on ECMO, they anticoagulate the patients fully with heparin or bivalirudin or another DTA. And also being on ECMO by itself can create coagulopathy by activation of platelets in some ways, or and essentially can cause bleeding, even being on ECMO without anticoagulation. So having a significant neurological injury like intracranial hemorrhage with or a stroke, a recent stroke that somebody can bleed into the it's a contraindication. I wanted to make a parenthesis here is most of our patients on ECMO, the most devastating and tragic side effects is to have an intracranial bleeding, a large intracranial bleeding. Because in the end, if everything else, if every organ survives, but the patient has a massive catastrophic brain injury, we failed. Finally, they mentioned that VV-ECMO is less likely to be beneficial in when it's active bleeding, of course, for the same reason. End-stage cancer, which essentially becomes futile. There's no point to keep the patient a month in the hospital or more when they have less than 1 year to live. It's counterproductive and maybe harmful for the patient and the family. Multi-organ dysfunction, which just makes sense, increases mortality. There's several scores, the SOFA scores, their SAP scores, the Apache scores, but essentially somebody who has multi-organ failure, especially with cirrhosis. Cirrhosis is a horrible condition and doesn't work well with ECMO for various reasons, infections, but mainly bleeding and encephalopathy. End-stage heart failure, I guess, again, the discussion there would be mostly for VA-ECMO and other support devices. And again, if there's a pathway, if it's going to be short-term or long-term recovery, or a bridge transplant or a device, bone marrow suppression. We're talking the patients will need multiple transfusions, extreme age, which is a little bit controversial. What is extreme age? Here it says about 65, but there could be 65 can become 75. A patient who is otherwise healthy for the biological age. So because the absolute age is not necessarily reflects the biological age. I'll say 65 to 75 in my opinion here. If you have an extremely healthy and fit 70-year-old. Importantly, the duration of mechanical ventilation. Also stating, highlighting here that 7 days or more or being on mechanical ventilation with high FiO2, it's a relative contraindication. So essentially, if somebody have someone with very, very bad ARDS that hasn't been progressing for 7 days or more, it makes sense to be a relative contraindication. And then going to the selection considerations. Again, we mentioned the hypoxemia, type 1, type 2 respiratory failure, respiratory acidosis. And then again, most of the selection considerations is the ones we mentioned from we're utilizing prior trials like the earlier trials, which is mentioned like a PF of less than 50 for 3 hours, or less than 60 for, less than 80 for 6 hours, or severe acidosis with a pH of less than 7.25, PCO2 greater than 60 for 6 hours, despite of being on having a plateau pressure as high as 32 and respiratory rate of 35. However, here we also adopted this criteria, which is mainly from the earlier study, but lower the plateau pressure to 30. And of course, the need for transplantation in addition to lung recovery. So it makes sense to the plateau pressure to be 30 is more concordant with the ARMA ARDS net studies than 32. Then the article here is discussing the scoring systems and prognostication. All right, jumping to scoring systems and prognostication. So the two major scores that are available, in addition to other newer scores that the preset, the ECM1, OneNet, and the preserve score, are mainly the Murray score. The Murray score we outlined earlier is based on the chest X-ray, how many quadrants are on the chest X-ray, the PF ratio, the PIP, and the compliance. It's a little hard to calculate on top of your head, so you may need a calculator, especially with the cutoffs in PF ratios are not the clear-cut cutoffs and the compliance. The RESP score is an interesting score that uses a lot of parameters. It seems it includes age, CO2, 75 or above, peak inspiratory pressures, immune status, mechanical duration, diagnosis, CNS dysfunction, pulmonary venous status, pulmonary infection status, pre-VV-ECMO parameters like neuromuscular blockage, nitric oxide, serum bicarb, and cardiac arrest. Jumping to the RES score for VV-ECMO, we have the QXMD website that has a nice calculator, and we have the parameters that we outlined before. It goes ahead to cite the article by Schmidt et al. From Blue Journal in 2014. By the way, this is actually a nice article that we may need to discuss in a further episode of our channel. It goes ahead and says the RESP score is calculated based on 12 pre-ECMO clinical variables that have independent association with hospital survival, And the higher the score, the more likely for the patients to survive. These scores developed based on the ELSO registry, and also it was further validated in a cohort of 140 patients. So let's start just to play with it. Say, let's use an age of 60 years old. Is a patient immunocompromised? That means this has been like tacrolimus, has been organ transplant recipient, bone marrow transplant, could be on chronic steroids for an ILD or an immune condition. So let's say the patient is not immunocompromised, and then if the patient is mechanically ventilated prior to ECMO initiation, let's say the patient is, like 7 days is the kind of the cutoff. Most of the studies, especially the ARDS, not to be included. So let's use 48 to 7 days. Let's say the patient has viral pneumonia and does not have CNS dysfunction, and he has infections. He has been on a neuromuscular blocker. He's on nitric or valetri or another inhaled prostaglandin. Bicarb used before ECMO, let's say, yes. And cardiac arrest before ECMO, no. CO2, let's say, is quite, let's say 65, and the peak inspired pressure it actually depends on the ventilator mode, but let's say is 40, let's say 45, and you see the results, and you see for this situation here, we have our RESP score outlined to be -5, which is risk class 4, and in hospital survival is 33%. And let's go back to our paper. And here our paper shows that makes our attention a note here that a high MERS score implies lower survival, while a high RESP score implies improved survival. Other prediction scores also exist, as you mentioned, etc. So RESP score, it seems that this is becoming an important prognostication tool. In subsequent episodes of our channel, we'll discuss the RESP score. As far as the duration of mechanical ventilation, this kind of makes a kind of elaborate discussion why the 7-day cutoff is used by also. Have the CESAR trial that use 7 days with a peak pressure above 30 and high FiO2s more than 80%. In the Eolia, they use as an exclusion the the 7 days cutoff in patients with plateau pressure of 32 and high FiO2s or high CO2s and acidosis. And finally, this review paper also cites some more studies that showed that in patients in a large registry analysis of 7,000 patients with COVID-19, they found that the longer when you're on the ventilator, you can see here, the longer you are on the ventilator, your survival drops. That makes it after being on ECMO. So that's another important point. And also, the same study found that ECMO is more effective in patients with driving pressures above 15. And again, driving pressures is a relatively new, the last like 10 years concept. They were looking mainly about the difference between the plateau pressures and the peak pressures. And essentially, the lower you have your driving pressure in patients with ARDS, the better it is for the lungs. That means you maximize recruiting of your lungs, and seems that it's better. And if your driving pressure runs higher, that means you're overstretching, you're not recruiting much lung. It's kind of also, there's other ways you can look at it, the stress index, etc., but it's beyond the scope of this. But this study found that patients with driving pressure above 15 had benefit from VV-ECMO. It was more effective, and makes sense because the VV-ECMO gave additional support, so minimizing the ventilator-induced lung injury. And of course, driving pressures have been associated with increased mortality during VV-ECMO support. So essentially, if somebody required higher driving pressures, both on ECMO and non-ECMO, they have higher mortality. And this concludes the first section of this paper. And now we're going to be discussing about cannulation. That means we're discussing about a little bit about the gas exchange dynamics, the cannula configurations, etc.